Hey guys, tonight we're stepping into the operating theatre of history. Not the kind with gleaming instruments and hand sanitizer stations. I mean the kind where the surgeon showed up drunk, the anesthesia was a leather strap to bite down on, and the mortality rate was so high they just built the hospitals next to cemeteries to save time. So before we drift off, take a second to like the video and subscribe, but only if you actually enjoy what I do here. Leave a comment telling me where you're listening from and what time it is for you. Somehow, it's always 2 a.m. somewhere, and you're all lying there thinking about medieval amputation techniques. Now, dim those lights, switch on a fan for that soft white noise, get comfortable, and try not to think too hard about the fact that antibiotics are only about 80 years old. Let's pause for a second. Have you ever wondered what a hospital smelled like before anyone discovered germs? Did doctors actually wash their hands before surgery? Or did they just wipe them on their already bloody aprons? What happened when you needed an operation before painkillers existed? Would you survive a simple infection in 1750? Or would that basically be a death sentence? Could you trust a surgeon who learned his trade by watching public executions and practicing on corpses stolen from graveyards? What did they use to sterilize surgical tools, whiskey, and prayer? And here's a fun one. Would you rather have surgery in a medieval monastery or a Civil War field hospital? Because honestly, both options are nightmare fuel. And now, congratulations, you've just woken up in a 19th century hospital ward. The year is 1847. The sheets haven't been changed in 3 weeks. Something is rotting in the corner that nobody's bothered to remove. The windows are nailed shut because fresh air is considered dangerous. The surgeon is approaching your bed with an unwashed scalpel, and he's humming cheerfully because he has absolutely no idea that his hands are covered in deadly bacteria. Good luck. Let's talk about what a hospital actually was for most of human history. Forget everything you know about modern medicine. Forget the sterile white rooms and the beeping monitors and the nurses who check your vitals every 4 hours. We're going back to a time when hospitals were basically holding pens for the dying. Picture this. You're lying in a bed that 3 other people have already died in this week. The sheets, if you can call them that, are stiff with old blood and other fluids we're not going to name. The patient to your left is moaning continuously. The patient to your right died sometime last night, but nobody's noticed yet because the staff is too busy. And honestly, corpse removal wasn't really a priority. The smell is indescribable, a combination of unwashed bodies, infected wounds, human waste, and something sweetly rotten that makes your stomach turn. There are no private rooms, no curtains, no dignity, just rows and rows of beds crammed so close together you can reach out and touch your neighbour, which you definitely don't want to do because whatever he has might be contagious. Welcome to the hospital ward, where the survival rate was so low that checking in was basically like writing your own obituary. In 18th century London, the typical hospital ward held anywhere from 30 to 60 patients in a single room. The beds weren't even beds in the modern sense. They were wooden frames with straw mattresses that were supposed to be changed regularly, but usually weren't. Sometimes 2 patients would share a single bed if space was tight, which was pretty much always. Imagine recovering from surgery while pressed up against a stranger with typhoid fever. That's not a nightmare scenario. That was Tuesday. The windows, when there were windows, were kept closed because of Miasma Theory, which we'll get to in a minute. But basically, doctors believed that night air was poisonous, so they'd seal up the wards after sunset, trapping all that wonderful infected air inside with you. By morning, the oxygen levels were so low that candles would barely stay lit. But hey, at least you were protected from the dangerous fresh air, right? Ventilation wasn't the only problem. Sanitation was virtually non-existent. Chamber pots were emptied maybe once a day if you were lucky. Sometimes they'd just overflow onto the floor, mixing with the blood and pus and whatever else was leaking from the patients around you. The floors were typically wood, not tile, so all those fluids would seep into the boards and just stay there, creating a permanent layer of biological contamination that no amount of sweeping could fix. The staff situation was equally grim. Nurses in this era weren't trained medical professionals. They were usually poor women, often widows, who needed work and didn't have many other options. Some of them were kind, many of them were drunk. Charles Dickens' portrayal of Sayuri Gamp in Martin Chuzzlewit wasn't much of an exaggeration. She was a drunk, incompetent nurse who cared more about gin than her patients, and she was based on the real nurses Dickens had observed in London hospitals. These nurses had impossible jobs. They were expected to care for dozens of patients at once with minimal supplies and no real medical knowledge. They'd change bandages without washing their hands first. They'd move from patient to patient, spreading infection like they were being paid by the germ. Not that they understood germ theory yet. Nobody did. Feeding patients was another nightmare. Hospital food in the 1700s and 1800s was famously terrible. Thin gruel, stale bread, occasionally some meat that was more gristle than actual protein. If you had a family member who could bring you food from outside, you were lucky. If you didn't, you got whatever the hospital provided, which was barely enough to keep you alive, let alone help you recover from illness or surgery. And here's perhaps the darkest detail. Hospitals were originally designed for the poor. Wealthy people got sick at home where they had their own beds, their own doctors making house calls, their own servants to care for them. Hospitals were charity institutions for people who had nowhere else to go. This meant the patient population was already malnourished, already weakened by poverty and poor living conditions. They came to the hospital as a last resort, and often the hospital finished the job that poverty had started. The mortality rate in some hospital wards reached 25% or higher. 1 in 4 people who checked in never checked out, and this wasn't considered a scandal. This was just how hospitals worked. Death was expected, normal, just part of the process. So when you hear people talk about the good old days before modern medicine got too complicated, before hospitals got too sterile and impersonal, remember this. You're romanticizing an era when hospitals were statistically more dangerous than staying home and taking your chances. Now, before we get into the truly horrifying stuff, we need to talk about what doctors actually believed about disease. Because for most of history, the entire medical establishment was operating under a theory that was, and I cannot stress this enough, completely wrong. It's called Miasma Theory, and it dominated Western medicine for literally thousands of years. The basic idea was that diseases were caused by bad air, poisonous vapours rising from rotting organic matter, sewage, corpses, swamps, basically anything that smelled terrible. If you could smell something foul, it would make you sick. If you breathed in the miasma, the bad air, you'd catch whatever disease was floating around in it. Cholera, bad air. Typhoid, bad air. The Black Death, you guessed it, bad air. The theory went back to ancient Greece. Hippocrates wrote about it. Galen endorsed it. For over 2,000 years, the smartest medical minds in the Western world looked at disease outbreaks, noticed they happened in places that smelled awful, and concluded that the smell itself was the killer. Now, here's the thing. Miasma theory wasn't completely insane. Cities in the 1800s did smell absolutely horrific, and diseases did tend to cluster in areas with poor sanitation. So the correlation was there, but the causation, completely backwards. Doctors thought the smell itself was the problem, not the actual bacteria and viruses breeding in the filth. So their solution to hospital infections wasn't to, clean things or wash their hands. It was to mask the smell. They'd burn incense, open windows to let in fresh air during the day, spray perfume around the wards. Some hospitals used aromatic herbs, lavender, rosemary, anything with a strong, pleasant scent, believing this would counteract the poisonous vapours. Meanwhile, they were still performing surgery with unwashed hands and reusing bandages from one patient to the next. Because, hey, it doesn't smell that bad, so it must be fine. It's like trying to fix your car by painting it while the engine is on fire. The miasma theory led to some genuinely bizarre medical practices. During cholera outbreaks, doctors would carry vinegar-soaked sponges to hold over their noses, believing this would protect them from the disease. Some wore elaborate beak-shaped masks filled with aromatic substances. Those creepy plague doctor masks you've seen in illustrations weren't just for show. They were actually designed to filter out the bad air. Rich people would carry pomanders, little decorative balls filled with perfume or spices to protect themselves when walking through poor neighbourhoods. The logic was that if you couldn't smell the poverty, you couldn't catch whatever diseases the poor people had. This, understandably, did not work. The really frustrating part is that miasma theory actually prevented doctors from discovering the real causes of disease. When someone would suggest that maybe diseases spread through physical contact or contaminated water, the medical establishment would dismiss it because everyone knew diseases came from bad air. Why waste time investigating other possibilities when the answer was already established? Take John Snow, the doctor who figured out that cholera was spreading through contaminated water in London during the 1854 outbreak. He traced cases back to a specific water pump on Broad Street, convinced authorities to remove the pump handle, and the outbreak stopped. Clear evidence that cholera was waterborne, not airborne, right? The medical establishment still didn't believe him. They thought he'd gotten lucky, that removing the pump had somehow improved the local air quality. Even Florence Nightingale, who revolutionized nursing and saved countless lives by improving hospital sanitation, was a firm believer in miasma theory. She thought diseases spread through foul air, and that fresh air and cleanliness would prevent infection. She was right about the cleanliness part, but for completely the wrong reasons. She thought she was clearing bad air when she was actually removing bacteria. The persistence of miasma theory meant that basic hygiene practices took decades longer to implement than they should have. Doctors resisted hand washing because they didn't think hands could transmit disease. After all, hands don't smell bad, so how could they be dangerous? The idea that invisible organisms could be the real culprit seemed ridiculous to men who'd spent their entire careers studying the relationship between foul odours and disease outbreaks. It wasn't until the 1880s, when germ theory finally gained acceptance and scientists could actually see bacteria under microscopes, that miasma theory started to die out. And even then, some doctors clung to it. They'd spent decades building their reputations on miasma theory. They'd written textbooks about it, taught it to students, built entire practices around it. Admitting they'd been wrong about something so fundamental was professionally devastating. So they kept spraying perfume in operating rooms while their patients died from infections that could have been prevented with soap and water. That's the legacy of miasma theory. Thousands of years of being confidently, catastrophically wrong. Let's move on to surgery, which in the pre-anesthesia era was less like a medical procedure and more like a live-action horror show. Surgical theatres weren't called theatres for nothing. They were actual amphitheatres with tiered seating where medical students, other doctors, and sometimes just random wealthy people who'd paid for a ticket would gather to watch operations. The patient would be strapped to a wooden table in the centre of the room, fully conscious, while the surgeon worked as fast as humanly possible because speed was the only advantage you had when your patient was screaming in agony. Think about that for a moment. You're lying on a table, leather straps across your chest and limbs, surrounded by a crowd of spectators leaning forward to get a better view, while a man with a saw prepares to cut off your leg. And you're awake for all of it. The fastest surgeons were the most famous. There are records of amputations being performed in under 2 minutes. Saw through the bone, tie off the major blood vessels. Next patient, please. Robert Liston, a Scottish surgeon in the 1840s, was legendary for his speed. He could amputate a leg in less than 30 seconds. His assistants had to be quick too, or they'd lose fingers. There's a famous, possibly apocryphal story about Liston performing an amputation so fast that he accidentally cut off his assistant's fingers along with the patient's leg. Both the patient and the assistant later died of gangrene, and a spectator was so horrified he died of shock. The only operation in history with a 300% mortality rate. The operating theatre itself was designed for maximum visibility. Rows of wooden benches rose up in a circle around the operating table, like a gladiatorial arena, except the entertainment was watching someone's leg get sawed off. The spectators weren't quiet either. They'd comment on the surgeon's technique, place bets on whether the patient would survive, sometimes heckle if they thought the surgeon was being too slow or clumsy. Medical students were required to attend these operations as part of their education. They'd crowd in close, trying to see every detail, sometimes dozens of them packed around a single table. The air would be thick with their body heat, their breath, and the smell of blood and terror. Imagine trying to concentrate on performing precise surgery while surrounded by a crowd of critics and your patient is screaming and trying to break free from the restraints. The floor was covered in sawdust to soak up the blood. By the end of a busy day, that sawdust would be saturated, dark, and sticky. The surgeon wore a coat that was stiff and black from dried blood and other fluids from previous operations, and this was considered a badge of honor, a sign of experience. The bloodier and stiffer your surgical coat, the more operations you'd performed, the more experienced you were. It was a status symbol. The same logic applied to the operating table. Some surgical theatres used the same wooden table for years without cleaning it properly. The wood would be stained dark brown, soaked through with blood and pus from hundreds of operations. They'd rinse it with water between patients, but that was about it. No disinfectant, no sterilization, just a quick wipe, and on to the next victim. The instruments weren't much better. Surgeons would use the same scalpels, saws, and clamps all day without cleaning them. They'd wipe them on their aprons, maybe rinse them in a bucket of water, and that was considered sufficient. The idea of sterilizing instruments between patients didn't exist. Why would it? According to Miasma Theory, infection came from bad air, not dirty tools. Between operations, the surgical instruments would just sit on a tray, covered in blood from the previous patient. Sometimes they'd be stored in a case lined with velvet, which sounds elegant until you realize that velvet is basically impossible to clean and becomes a permanent breeding ground for bacteria. But hey, at least it looked impressive. The unwashed coat, the unwashed hands, the unwashed instruments, everything was reused, nothing was sterilized, and infection rates were so astronomically high that patients often survived the surgery only to die days later from gangrene or sepsis. The surgeon would amputate your leg perfectly. You'd survive the shock and blood loss, and then a week later, you'd be dead from infection that started in the wound. But here's the worst part. None of this was considered a failure. Post-operative infection was just accepted as normal, an unavoidable consequence of surgery. They called it laudable pus. The pus that formed in your wound after surgery was thought to be a good sign, evidence that your body was healing. If your wound was oozing thick white or yellow pus, your doctor would nod approvingly and tell you everything was going well. Spoiler alert, it wasn't. It was evidence that you were dying. That laudable pus was your wound being consumed by bacterial infection. But because they didn't understand germ theory, they interpreted infection as healing. It's like thinking smoke coming from your engine means your car is working extra well. The surgical theatre represented the pinnacle of pre-modern medicine. Confident, dramatic, completely public, and absolutely deadly. Now let's talk about amputations specifically, because if you were a soldier, a sailor, or just someone unlucky enough to get a badly broken leg in the 1700s or 1800s, amputation was the go-to solution for pretty much everything. Got a musket ball lodged in your shin? Amputation. Compound fracture? Amputation. Infected finger? Better take the whole arm just to be safe. The logic was actually somewhat sound, given what they knew at the time. If you had a severely injured limb, there was no way to set complicated fractures, no way to remove embedded foreign objects without causing more damage, and no antibiotics to fight infection. Once gangrene set in, it would spread up the limb and kill you. So the solution was simple. Cut off the infected part before the infection spreads. Crude, but effective. Sometimes. The speed of these operations was genuinely horrifying. The most famous surgeon of the Napoleonic era, A man named Dominique Larry could reportedly amputate a leg at the hip in under 90 seconds. 90 seconds. From the first cut to the final stitch, a minute and a half. Think about that. You can't even make a decent cup of coffee in 90 seconds, and this man was removing entire limbs. This was considered a point of pride, a demonstration of skill. Because remember, there's no anesthesia yet. Your patient is awake, screaming, trying to fight you off, held down by assistants whose only job is to keep you on the table. The human body has a remarkable capacity for shock. Your blood pressure drops, you might pass out, your brain tries to protect you from the trauma. But you can only count on that for so long. The faster you work, the less time the patient has to go into shock and die. So surgeons develop techniques for maximum speed. They'd make their incision strategy in advance, where to cut, how deep, which blood vessels to tie off first. Everything was planned for efficiency. The actual procedure went like this. First, you'd cut through the skin and muscle in one circular motion around the limb, like you're peeling a really horrifying banana. Then you'd pull back the skin and muscle to expose the bone. Then came the saw, quick, firm strokes through the bone, trying not to splinter it because bone fragments would cause complications later. Once the bone was severed, you'd have assistants pull back the skin and muscle even further, while you frantically tied off the major arteries before the patient bled out. This part was critical and required actual skill. Miss an artery and the patient could bleed to death in minutes. The arteries were tied with whatever thread was handy, often just regular sewing thread. Not even surgical catgut. Sometimes silk if you were fancy. The thread would be left long, hanging out of the wound, so it could be removed later once the blood vessels had sealed themselves off. Then you'd fold the remaining skin over the stump and sew it shut. Quick stitches, nothing fancy. The goal was to close the wound fast and move on to the next patient. In a major battle, there could be dozens or even hundreds of men waiting for amputation, all of them screaming or moaning or unconscious from blood loss. The surgeon didn't have time for precision or artistry. The survival rate for these lightning-fast amputations was, optimistically, about 50%. That's a coin flip. Heads you live, tails you die. And that's if you survive the surgery itself. Most people died later from infection. But hey, at least the surgeon got a round of applause from the medical students watching in the gallery. Different surgeons had different styles. Some preferred the circular method I just described. Others used the flap method, where you'd cut flaps of skin and muscle that could be folded over the bone stump more neatly. The flap method took longer, but allegedly healed better. Allegedly. Most patients died of infection regardless, so the aesthetic quality of your stump wasn't really the primary concern. The instruments were surprisingly simple. A good sharp knife for cutting through skin and muscle. A bone saw, literally just a saw, the same kind you'd use for carpentry. A set of forceps for grabbing blood vessels. Some thread and a needle for stitching. That was basically the entire amputation kit. No clamps to stop bleeding, no specialized surgical instruments, just the basics. Surgeons would sharpen their saws between operations, but that was about the extent of maintenance. The saw would accumulate a layer of bone dust and dried blood that gave it texture, almost like seasoning a cast iron pan. Experienced surgeons could tell you stories about their favorite saws, the ones that had been through hundreds of amputations and still cut clean. After the operation, the patient would be carried to a recovery area and left to heal or die. The stump would be wrapped in bandages that wouldn't be changed for days. If you survived the initial shock and didn't bleed out, you still had to get through the infection phase, which usually started about 3 or 4 days after surgery. Your stump would swell up, turn red, start oozing that laudable pus we talked about. Fever would set in, delirium, and then either your body fought off the infection or you died. The ones who survived would be fitted with wooden prosthetics, assuming they could afford them. A simple wooden peg leg for below-knee amputations, more complex jointed prosthetics for above-knee. Upper limb amputations got hooks or simple wooden hands. Nothing fancy, nothing functional, just something to make you look slightly less incomplete. But at least you were alive, which was more than could be said for roughly half the men who went under the saw. Here's a story that will make you genuinely angry. In the mid-1800s, there was a hospital in Vienna with 2 maternity wards. Same building, same basic setup, same city, same era. But one ward had a death rate of around 10%, while the other had a death rate closer to 3%. Women would literally beg not to be admitted to the deadlier ward. Some would rather give birth in the street than go into that wing of the hospital. Think about that. Women were so terrified of the doctor's ward that they'd risk giving birth on the street, in the gutter, surrounded by sewage and rats, because even that was statistically safer than the hospital. That's how bad it was. The cause of death? Childbed fever, also called puerperal fever, a bacterial infection that would set in shortly after childbirth and kill women within days. You'd deliver your baby successfully. Everything would seem fine. And then a day or 2 later, you'd develop a fever. The fever would get worse. Your abdomen would swell and become painful. You'd become delirious. And then you'd die, usually within a week of giving birth, leaving behind a newborn who'd probably die soon after, because infant mortality was also catastrophic. And here's what made it so infuriating. The difference between the 2 wards was the staff. The deadly ward was staffed by doctors and medical students. The safer ward was staffed by midwives. That's it. That was the only significant difference. And yet women in the doctor's ward were dying at 3 times the rate of women in the midwives' ward. A young doctor named Ignaz Semmelweis started investigating, and he noticed something horrifying. The doctors and students in the deadly ward would go directly from performing autopsies in the morgue, cutting open corpses, examining diseased organs with their bare hands, literally elbow deep in dead bodies, to delivering babies without washing their hands. They'd rinse their hands in a basin of water, maybe, if they felt like it, but mostly they'd just wipe them on their aprons and head upstairs to the maternity ward. The midwives didn't do autopsies, they just delivered babies. That was the difference. The doctors were carrying death on their hands, literally, from the morgue to the delivery room. They were killing women with bacteria from corpses. Semmelweis started collecting data. He noticed that the mortality rate spiked after anatomy lessons, when the students would spend the morning dissecting cadavers and then spend the afternoon delivering babies. He noticed that women who gave birth before making it to the hospital, in carriages, in the street, anywhere outside the hospital, had lower mortality rates than women who delivered in the doctor's ward. He even noticed that the ward's mortality rate would drop during periods when the medical students were on break and weren't doing autopsies. The pattern was clear. It was the doctors. They were the problem. They were spreading the infection. So Semmelweis proposed a revolutionary idea. What if the doctors washed their hands with a chlorine solution before examining patients? Not just a rinse with water, but an actual disinfectant that would kill whatever was causing the infections. He implemented the policy in his ward. Mandatory hand washing with chlorinated lime solution before every patient examination. The death rate in the doctor's ward plummeted immediately. It dropped from around 10% to under 2% almost overnight. Women stopped dying. Families stopped mourning. The evidence was clear, dramatic, and undeniable. Problem solved, right? Wrong. You'd think he'd be celebrated as a hero, paraded through the streets, given awards and honours. Instead, the medical establishment turned on him viciously. They refused to believe that they, educated gentlemen, could be the ones spreading disease. The idea that doctors could be killing their patients was professionally insulting. These were men who'd spent years in medical school, who'd studied the classics, who understood humoral theory and miasma theory and all the established medical wisdom. And now some upstart was suggesting they were murderers. Semmelweis was mocked, marginalized, dismissed from his position. Other doctors accused him of being obsessed, of making wild accusations without proof. Never mind that the death rates had dropped. Never mind that the evidence was sitting right there in his mortality statistics. They didn't want to believe it, so they didn't. Part of the resistance was theoretical. Germ theory didn't exist yet. The idea that invisible organisms could cause disease hadn't been established. So when Semmelweis said that something on the doctor's hands was killing women, he couldn't explain what that something was. He just knew it worked. But the medical establishment demanded theoretical explanations. They wanted to know the mechanism, the why, not just the what, and Semmelweis couldn't provide that. Part of the resistance was also practical. Washing your hands with chlorine solution was unpleasant. It dried out your skin, made your hands crack and bleed, smelled terrible. Doctors didn't want to do it. They were busy. They had lots of patients. Stopping to scrub their hands between each examination was time-consuming and annoying. But mostly, the resistance was ego. Admitting that hand-washing worked meant admitting that they had been killing women for decades through their own negligence. It meant admitting that the learned physicians with their university degrees were less safe than illiterate midwives. That was too much for them to accept. Semmelweis grew increasingly frustrated and bitter. He started writing angry letters to prominent doctors, calling them murderers, accusing them of having blood on their hands. This did not help his case. He became erratic, obsessive, unable to let go of the fact that he'd solved the problem, and nobody would listen. Eventually, he was committed to a mental asylum. The official reason was that he was showing signs of mental instability, which he probably was, after years of watching women die unnecessarily while the medical community ignored his solution. 2 weeks after being committed, Semmelweis died from infected wounds after being beaten by asylum guards. He was right, and it killed him. His ideas would eventually be vindicated when germ theory became established in the 1880s. But by then, he'd been dead for 15 years, dismissed and forgotten by the profession he tried to save. Medical education in the 18th and 19th centuries had a bit of a problem. Doctors needed to learn anatomy, which meant they needed cadavers to dissect. You can't learn where the organs are, how the muscles attach, where the major blood vessels run, without actually cutting open bodies and looking inside. Textbooks and diagrams can only teach you so much. Eventually, you need hands-on experience. But there were never enough legal cadavers to go around. Executed criminals were the main source. After you were hanged, your body became property of the surgeons for anatomical study. This was actually written into law in many countries as an additional punishment. Not only would you die, but your body would be publicly dissected, denying you a proper burial. For people who believed in physical resurrection, this was genuinely terrifying. But there were only so many hangings in a year, maybe a few dozen in a major city, and medical schools were expanding rapidly. The demand for cadavers far outstripped the legal supply, so a black market developed. Grave robbers, politely called resurrectionists, would dig up freshly buried corpses and sell them to anatomy schools for cash. It was a lucrative business if you could handle the smell and the moral implications. Fresh corpses, meaning ones that had been dead for less than a week and weren't too decomposed, could fetch £10 or more, which was serious money in an era when a labourer might earn £50 a year. A single corpse was worth about 3 months of wages for a working man. The resurrectionists would work at night, obviously. They'd scout out graveyards during funerals, noting which plots had recent burials. Then they'd return after dark with shovels and a cart. The technique was actually somewhat sophisticated. They wouldn't dig up the entire grave. That would take too long and leave obvious evidence. Instead, they'd dig down at the head end of the coffin, break open just the top portion, and pull the body out through the hole. Then they'd refill the grave, and by morning it would look relatively undisturbed. Unless someone was specifically looking for signs of disturbance, they wouldn't notice. Sometimes they'd strip the corpses before selling them, because legally stealing a body wasn't technically theft. A corpse wasn't property under English law, but stealing the clothes was. So they'd leave the burial clothes in the coffin to avoid the more serious charge. Naked corpse? Not technically illegal. Corpse plus clothes? That's theft. That'll get you hanged. The legal system was weird. Families started taking precautions. Rich people would pay for mort safes, heavy iron cages that would be placed over the grave to prevent digging. Or they'd bury their dead in vaults instead of simple graves. Some graveyards hired watchmen to patrol at night. Some families would mount a watch themselves, sleeping in the graveyard for the first few nights after burial until the body decomposed enough to be useless for anatomical study. It became an arms race. Resurrectionists got better tools, better techniques. Graveyards got better defences. Some places installed alarm systems, tripwires connected to bells that would alert watchmen if someone was digging. But a motivated resurrectionist could usually find a way. The anatomy schools knew exactly where these bodies came from. They had to know. The supply was too consistent, too reliable, but they maintained plausible deniability. They'd pay cash, no questions asked, no records kept. Everyone involved understood it was illegal, but everyone also understood it was necessary if doctors were going to be properly trained. And if you're thinking, well, at least they were only digging up people who were already dead, let me introduce you to Burke and Hare, 2 men in Edinburgh who decided that digging up corpses was too much work. Why spend hours in a graveyard with a shovel when you could just create your own corpses? Much more efficient. Between 1827 and 1828, William Burke and William Hare murdered 16 people and sold their bodies to Dr. Robert Knox, a prominent anatomy lecturer at the University of Edinburgh. Their method was straightforward. They'd target people who wouldn't be missed: homeless people, prostitutes, travellers, get them drunk, and then suffocate them in a way that didn't leave obvious marks. Then they'd deliver the fresh corpse to Dr. Knox, who would pay them £7 to £10 per body and ask no questions about why these corpses were so conveniently fresh and unmarked by disease. Dr. Knox had to have known something was wrong. 16 suspiciously fresh bodies in about a year, all of them conveniently available right when he needed them for demonstrations. But the bodies were high quality, perfect for anatomical study, and he needed the supply for his lectures. So he didn't ask questions. They were finally caught when other lodgers discovered one of the victims' bodies hidden under a bed. Burke and Hare were arrested. Hare turned King's evidence, testified against Burke in exchange for immunity. Burke was convicted and hanged in January 1829. And here's the beautiful irony. After Burke was hanged, his body was publicly dissected by Alexander Monro, Professor of Anatomy at the University of Edinburgh. 25,000 people came to view the dissection. Burke's skeleton was preserved and is still on display at the Anatomy Museum of the Edinburgh Medical School. You can visit him. They even made a pocketbook out of his skin, which is also on display because apparently they wanted to be extra thorough with the poetic justice. Dr. Knox was never charged with any crime. His reputation was damaged, but he continued practicing medicine. The whole affair sparked public outrage and contributed to the passage of the Anatomy Act of 1832, which expanded the legal supply of bodies for medical schools by allowing them to use unclaimed bodies from workhouses and hospitals. This reduced the need for grave robbing, but didn't eliminate it entirely. The resurrection trade continued well into the mid-1800s, though with less frequency as the legal supply improved. But for decades, medical education in Europe and America was built on stolen corpses, and everyone involved, the resurrectionists, the medical schools, the students, the professors, just accepted it as the price of progress. Military medicine deserves its own special circle of hell. Imagine you're a soldier in, say, the American Civil War. You've just been shot in the leg during battle. The musket ball has shattered your femur, and you're bleeding badly, but still alive. Your fellow soldiers drag you off the battlefield and carry you to a field hospital, which is usually just a tent or a commandeered barn somewhere behind the lines. The operating table is a door ripped off its hinges and propped on barrels. Or it's a wooden plank. Or it's just a section of floor that's been cleared of debris. The surgeon, who may or may not have actual medical training, Civil War surgeons, were often just regular doctors drafted into service with minimal surgical experience, is already covered in blood from the previous dozen patients. There's no time to clean instruments between operations, no time to wash hands. The saw used on the last amputation is the same saw they'll use on you, still sticky with the previous guy's blood and bone fragments. The surgeon might wipe it on his apron between patients, but that apron is already soaked through with blood, so you're not really cleaning anything, just redistributing the bacteria. Anesthesia exists by this point, chloroform and ether, but supplies are limited. especially after the first day or two of a major battle when everything starts running out. Sometimes the anesthesia is saved for officers, while enlisted men just have to bite down on a bullet or a leather strap and endure it. Sometimes there's simply none left, and everyone suffers fully conscious surgery. The triage system is brutal in its efficiency. The surgeons would quickly categorize incoming wounded into 3 groups: those who would probably die even with treatment, those who would probably survive without treatment, and those who might survive with immediate intervention. Only that 3rd group got the surgeon's attention. If you were too far gone, you'd be moved to a corner to die as comfortably as possible, which usually meant not very comfortably at all. If your wounds were minor, you'd be patched up by assistants and sent back to your unit. But if you fell into that middle category, seriously wounded but potentially salvageable, you'd get surgery. And the surgery itself was brutal and fast. They amputated thousands of limbs during major battles, sometimes hundreds in a single day. The pile of severed arms and legs outside the surgical tent grows higher and higher throughout the day, a grotesque monument to the battle's casualties. Soldiers would later report seeing these piles, some stacked as high as a man's chest, just sitting there in the sun while flies swarmed over them. The most common battlefield injury requiring surgery was the gunshot wound. Civil War musket balls were large, soft lead projectiles that would flatten on impact and cause massive tissue damage. They'd shatter bones, tear through muscles, carry bits of dirty clothing deep into the wound. Trying to save a limb that had been hit by a musket ball was usually pointless. The damage was too extensive, the risk of infection too high. So amputation became the default treatment. The surgery itself took maybe 15 to 20 minutes if the surgeon was experienced. Longer if he wasn't, or if there were complications. Cut through the skin and muscle, saw through the bone, tie off the arteries, stitch it closed. Next patient. Some surgeons got so fast they barely looked at what they were doing, working by touch, their hands moving automatically through the familiar motions while their minds were already on the next patient. After your amputation, you'd be carried to a recovery area with dozens of other wounded men, all of you sharing the same flies, the same filth, the same infections. The recovery areas were often worse than the operating areas. At least in the operating tent, there was some semblance of medical care happening. In recovery, you were just lying on the ground or on a cot if you were lucky, waiting to see if you'd survive. The mortality rate from battlefield wounds wasn't primarily from the wounds themselves. It was from the infections that inevitably followed. A man could survive the initial injury, survive the surgery, survive the shock and blood loss, and then die a week later from gangrene or sepsis. The infection rate for amputations was nearly 100%. Every single amputation got infected. The only question was whether your body could fight it off before it killed you. Gangrene was the big killer. The wound would turn black, start to rot, smell like death. Surgeons could recognize the smell of gangrene from across the tent. If gangrene set in, your only hope was re-amputation, cutting higher up the limb, above the infection, trying to stay ahead of the spread. Sometimes men would have 2 or 3 amputations, losing more of their limb each time until there was nothing left to cut, or they finally died from the cumulative trauma. The medical supplies ran out quickly during major battles. Bandages, chloroform, laudanum for pain, even basic items like thread for stitching. everything would be depleted within the first day. Surgeons would start reusing bandages, just rinsing them in water and wrapping them on the next patient. They'd ration the pain medication, giving smaller and smaller doses to make it last, until eventually there was none left, and men just had to suffer. Food and water for the wounded were also scarce. Supply lines during battle were focused on getting ammunition and food to the active troops, not on supporting the medical services. Wounded men might go days without proper food, surviving on whatever the surgeons could scrounge. Dehydration was a serious problem, especially for men who'd lost a lot of blood. And if you think the surgeons were calm, professional, detached medical practitioners calmly doing their jobs, you'd be wrong. Many of them were barely holding it together. They'd work for 18, 20, 24 hours straight during major battles, performing amputation after amputation until their hands cramped and their judgment blurred from exhaustion. Some of them turned to alcohol to cope, operating drunk because sober they couldn't handle the endless stream of screaming men and the knowledge that most of them would die anyway. The psychological toll on the surgeons was enormous. After a major battle, they'd have amputated hundreds of limbs, watched hundreds of men die despite their best efforts, and sent hundreds more to recovery, knowing most of them would be dead within a week. And then the next battle would come, and they'd do it all over again. But you know what the worst part was? The survival rate for battlefield injuries during the Civil War was actually better than in previous wars. Medicine was improving, slowly. The surgeons were getting better at their jobs, developing better techniques, learning from experience. But better doesn't mean good. It just means less catastrophically awful. For most of medieval and early modern Europe, if you needed surgery, you didn't go to a doctor. You went to your barber. Yes, the same guy who trimmed your beard and cut your hair would also pull your teeth, lance your boils, set your broken bones, and amputate your gangrenous limbs. This wasn't some weird quirk of history. This was the official system, established by guild regulations and endorsed by authorities. Physicians, who were university educated and considered gentlemen, viewed surgery as beneath them. Cutting into people was manual labour, dirty work, something a gentleman wouldn't stoop to do. Physicians were theoreticians. They studied Galen and Hippocrates. They understood the four humours. They could diagnose imbalances and prescribe treatments. But actually laying hands on a patient, opening bodies, dealing with blood and pus, that was beneath their station. So surgery fell to the barbers, who were organised into guilds just like any other tradesman: blacksmiths, carpenters, tailors. The Worshipful Company of Barber Surgeons was established in London in 1540, merging the separate barber and surgeon guilds into one organisation. You get your hair cut, you shave, and if needed, your tooth pulled, all from the same establishment. The iconic barber pole, red and white stripes spiralling up a pole, actually represents blood and bandages, a holdover from the days when barbers were surgeons. Some versions include a blue stripe representing veins. The pole itself supposedly represents the stick that patients would grip during bloodletting to make their veins stand out. So every time you see a barber pole, you're looking at a medieval surgical advertisement. These barber surgeons learned their trade through apprenticeships, not formal medical education. A boy would apprentice to a master barber surgeon for 7 years or so, learning by watching and assisting. First, you'd learn the basic barbering, how to cut hair, trim beards, shave without cutting the customer's throat, which was actually a valuable skill when you're using a straight razor on someone's neck. Then you'd progress to the medical procedures. Bloodletting was the most common. According to humoral theory, most illnesses were caused by an imbalance of fluids in the body, and removing some blood would restore balance. So barber surgeons would use lancets to open veins and drain blood into a bowl. The amount varied, sometimes just a few ounces, sometimes a pint or more. They'd also apply leeches, which would attach to the skin and drink blood until they were fat and satisfied. Tooth extraction was another specialty. Dental care in this era was basically non-existent. When a tooth started hurting, you'd let it rot until the pain became unbearable, and then you'd go to the barber surgeon to have it pulled. No anesthetic, just a strong grip on your head and a quick yank with a pair of tooth-pulling forceps. If the tooth broke during extraction, which happened frequently, the barber surgeon would have to dig around in your gum to remove the fragments. Wound care was a major part of the business. In an era when most men carried knives and fights were common, stab wounds and cuts were regular occurrences. The barber surgeon would clean the wound, sort of, stitch it up if necessary, and bandage it. The survival rate for even minor wounds was terrible because of infection, but that wasn't seen as the barber surgeon's fault. That was just how wounds were. Setting broken bones was another service. If you broke your arm or leg, the barber surgeon would manipulate it back into roughly the right position, splint it with wooden boards and bandages, and hope it healed straight. Sometimes it did, often it didn't. Crooked, poorly healed bones were common, leaving people with permanent disabilities. And then there were the amputations. When a limb was too damaged or too infected to save, off it came. The barber surgeon's tools were simple: knives, saws, cauterizing irons heated in a fire to seal wounds and stop bleeding. The procedure was the same as in the surgical theatres we talked about earlier. Fast, brutal, with the patient conscious and screaming. Except the barber surgeon was doing this in his shop. Not an operating theatre, probably in the same room where he cut hair that morning. The mortality rate was horrifying, but again, this wasn't necessarily seen as the barber surgeon's fault. People understood that surgery was dangerous. If you survived, great. If you didn't, well, you were probably going to die anyway. At least the barber surgeon tried. There was no understanding of infection, no concept of sterilization. The same razor that shaved your face in the morning might amputate someone's leg in the afternoon, with maybe a quick wipe on an apron in between. The same workspace where hair clippings accumulated on the floor would be used for surgery. The same basins of water for rinsing razors would be used for cleaning surgical instruments. And yet, weirdly, some of these barber surgeons were actually quite skilled. Without the burden of incorrect medical theory, they developed practical techniques that worked. They learned through experience what helped patients survive and what didn't. They couldn't explain why certain practices led to better outcomes, but they noticed the patterns and adjusted accordingly. Some barber surgeons specialized in particular procedures. There were lithotomists who specialized in removing bladder stones through a perineal incision, a genuinely skilled and dangerous procedure with about a 50-50 survival rate. There were herniotomists who specialized in hernia repairs. There were cataract surgeons who would couch cataracts, pushing the clouded lens down into the eye to restore partial vision. The division between physicians and surgeons lasted for centuries. It wasn't until the 1700s that surgery started gaining respectability as a learned profession. The company of surgeons separated from the barbers in 1745, and surgery gradually became a proper medical specialty requiring formal education. But even then, the stigma remained. Surgeons weren't called doctor in Britain until well into the 1800s. They were just Mr., a title they've kept even after gaining equal status with physicians. So the next time you get your hair cut, take a moment to appreciate that your barber probably isn't going to amputate your leg afterward. That's progress. Let's talk about the moment when surgery stopped being pure torture, the invention of anesthesia. Before the 1840s, if you needed an operation, you were awake for all of it. You felt everything. The only options for pain management were alcohol, get the patient drunk enough that they might pass out from the pain, or opium, which dulled the pain somewhat but didn't eliminate it and left you drowsy and constipated, but still very much aware that someone was sawing through your leg. Some surgeons would try to numb the area with ice or cold water, but that only worked for superficial procedures and only provided minimal relief. Some would try compression, cutting off blood flow to the limb to reduce sensation, but again, limited effectiveness, and you still felt the bone being sawed through. Mostly, patients just had to endure it, bite down on something, try not to move, try not to go into shock, and pray the surgeon worked quickly. Then, in October 1846, a dentist in Boston named William Morton successfully demonstrated ether as a surgical anesthetic. A patient inhaled ether vapor from a specially designed inhaler, fell unconscious, and a surgeon named John Collins Warren removed a tumor from his neck. The patient woke up afterward with no memory of the procedure and minimal pain. The first words the surgeon reportedly said after completing the operation were, "Gentlemen, this is no humbug." It was revolutionary. Within months, news of the ether demonstration had spread across America and Europe. Doctors everywhere started experimenting with ether anesthesia. Surgical theatres that had been places of screaming and terror became quiet, peaceful almost. Patients would breathe in the ether vapour, counting backward, and then just sleep. The surgeon could work at a normal pace instead of racing against time and shock. But ether had problems. It was irritating to the lungs, causing coughing and sometimes lasting respiratory issues. The vapour was highly flammable. You couldn't use it anywhere near open flames or gas lamps, which were the standard lighting in operating rooms. And the dosage was tricky. Too little, and the patient would wake up mid-surgery. Too much, and you could kill them. A year later, in 1847, a Scottish obstetrician named James Simpson discovered that chloroform worked even better than ether. It was faster acting, more potent, didn't irritate the lungs as much, and smelled relatively pleasant, sweet actually, which made it easier to convince patients to inhale it. Simpson tested it on himself and his friends at a dinner party, which was either brave or monumentally stupid, depending on your perspective. They all passed out and woke up hours later with headaches, but otherwise unharmed. Simpson immediately started using chloroform in his obstetrics practice, administering it to women during childbirth. This was controversial because there was a biblical passage suggesting that women should suffer in childbirth as punishment for Eve's sin. Some religious leaders argued that removing the pain of childbirth was going against God's will. Simpson, who was deeply religious himself, countered with another biblical passage. God put Adam to sleep before creating Eve from his rib. So clearly anesthesia for medical procedures was divinely approved. That seemed to settle the theological debate. The real turning point came in 1853 when Queen Victoria used chloroform during the birth of her 8th child, Prince Leopold. Her physician, John Snow. Yes, the same John Snow who figured out that cholera was waterborne, administered the chloroform, and the Queen later wrote about it approvingly in her diary. That royal endorsement basically made chloroform mainstream. If it was good enough for the Queen, it was good enough for everyone else. Suddenly, surgeons could take their time. They could perform complex operations that would have been impossible when the patient was thrashing and screaming. They could explore internal organs, repair complicated injuries, remove tumours from deep within the body. Operations that had been limited to amputations and surface procedures could now extend to abdominal surgery, thoracic surgery, neurosurgery, fields that hadn't really existed before because you couldn't cut into the chest or abdomen while the patient was conscious. But here's the dark irony. Anesthesia, for all its benefits, actually made infections worse in the short term. Because now that surgeons could take their time, they did. Operations that used to take 2 minutes now took 30 minutes, an hour, even longer. Complex abdominal surgeries could take several hours, and every extra minute your body cavity was open to the filthy air of an unsanitary operating room increased your risk of infection. Before anesthesia, most patients died from shock and blood loss during surgery. After anesthesia, most patients survived the surgery itself but died days later from infection. The mortality rate actually stayed about the same, or got slightly worse because surgeons were attempting more complex procedures that exposed patients to infection for longer periods. Chloroform itself wasn't without risks. The dosage was tricky. Different patients had different tolerances, and it was easy to give too much and stop the heart. There were deaths from chloroform overdoses, though not as many as you might expect, given how primitive the administration methods were. Usually, an assistant would just hold a chloroform-soaked rag over the patient's face and monitor their breathing and pulse. If the pulse got too weak or the breathing too shallow, they'd remove the rag and let the patient recover a bit before continuing. Some patients developed what was called chloroform syncope, a sudden cardiac arrest during anesthesia, usually in young, healthy patients. For reasons that weren't understood at the time, it's now thought to be related to sensitization of the heart to adrenaline. But in the 1800s, it was just a mysterious risk. You could be a perfectly healthy person going in for routine surgery, inhale the chloroform, and your heart would just stop. Terrifying for everyone involved. Despite these risks, anesthesia was immediately and universally recognized as a massive improvement over conscious surgery. The benefits so obviously outweighed the risks that within a decade, anesthesia became standard practice throughout the Western world. Surgeons who didn't use anesthesia were considered barbaric, backward. Anesthesia was a miracle, but it would take another innovation, antisepsis, which we'll get to next, to actually make surgery safe. You needed both. The anesthesia to make surgery humane, and the antisepsis to make it survivable. And finally, we arrive at Joseph Lister, the man who figured out that maybe, just maybe, we should try to kill the germs before they kill the patient. In the 1860s, Lister was a surgeon in Glasgow, and he was obsessed with the problem of post-operative infection. He'd seen too many successful surgeries turn into deaths a week later when the wound became infected and gangrenous. At the time, the prevailing theory was still miasma. Bad air caused infections. So hospitals would ventilate their wards, trying to clear out the poisonous vapours. But the infection rates stayed stubbornly high. Lister started wondering if there was something else going on, something they were missing. Then he read about Louis Pasteur's work on fermentation and putrefaction. Pasteur had demonstrated that microorganisms cause decay in organic matter. He'd shown that if you could kill these microorganisms through heat or chemicals, you could prevent spoilage. Lister had a revelation. What if the same principle applied to surgical wounds? What if invisible organisms were getting into the wounds and causing infection? This was revolutionary thinking. Germ theory wasn't established yet. Most doctors still believed in miasma. The idea that microscopic creatures were responsible for disease seemed far-fetched, almost ridiculous. You couldn't see them. Microscopes existed but weren't common in hospitals, so how could they be the problem? But Lister was willing to experiment. He started thinking about how to kill these hypothetical organisms. He needed something strong enough to destroy microorganisms, but not so toxic that it would harm the patient or prevent healing. He settled on carbolic acid, also called phenol, a harsh chemical derived from coal tar that was used to treat sewage and deodorize outhouses. If it could kill whatever made sewage smell terrible, maybe it could kill whatever caused infections. He started experimenting in 1865. He'd spray carbolic acid in the operating room, creating a mist that filled the air. He'd soak his instruments in it before surgery. He'd wash his hands with it. He'd even spray it directly onto open wounds during operations, which must have been excruciatingly painful for patients even under anaesthesia, since carbolic acid burns tissue. He also developed the carbolic acid dressing, bandages soaked in diluted carbolic acid that would be applied to wounds after surgery. The idea was that the dressing would prevent atmospheric germs from entering the wound and would kill any organisms that tried to colonize the site. The results were dramatic. His post-operative infection rates dropped from around 50%, meaning half his patients developed infections, to under 15%. Patients who would have certainly died from gangrene or sepsis were surviving and recovering fully. The evidence was clear and compelling. In 1867, Lister published his findings in The Lancet, one of the most prestigious medical journals in the world. He laid out his theory, his methods, and his results. You'd think the medical community would immediately embrace this life-saving technique. You'd be wrong. Just like Semmelweis before him, Lister faced fierce resistance. Other surgeons mocked him, called his methods unnecessary and overly complicated. They complained that carbolic acid was irritating and unpleasant to work with. It dried out their hands, made their eyes water from the spray, smelled terrible. Some tried it half-heartedly, didn't follow the protocols correctly, got poor results, and concluded it didn't work. Part of the problem was that Lister's technique was demanding. You couldn't just casually spray some carbolic acid around and call it antiseptic surgery. You had to follow strict protocols, sterilize all instruments, maintain the carbolic spray throughout the operation, apply the dressings correctly, monitor the wounds carefully. It required discipline and attention to detail that many surgeons didn't want to bother with. There was also the theoretical resistance. Germ theory still wasn't universally accepted. Many prominent surgeons still believed in miasma theory, and they rejected Lister's ideas because they rejected the underlying theory. If diseases came from bad air, not germs, then spraying carbolic acid made no sense. Some surgeons thought Lister's improved results were because the carbolic acid purified the air, not because it killed germs in the wound. They were so close to understanding, and yet so far. But gradually, painfully, slowly, the evidence became impossible to ignore. Hospitals that adopted Lister's methods saw their mortality rates drop. Hospitals that didn't continued losing patients to infection. Young surgeons who'd been trained in antiseptic technique achieved better results than older surgeons who stuck to traditional methods. The data was overwhelming. By the 1880s, antiseptic surgery was becoming standard practice throughout Europe and America. Operating rooms were being redesigned with cleanliness in mind. Walls and floors were made from materials that could be washed down with disinfectant. Instruments were sterilized in boiling water or chemical solutions before each use. Surgeons wore clean gowns and washed their hands before operations, not just rinsing, but actually scrubbing with carbolic acid or other antiseptics. The practice evolved from antiseptic surgery, killing germs during the operation, to aseptic surgery, preventing germs from entering the operating room in the first place. Surgeons started wearing sterile gloves, face masks, surgical caps. Operating rooms became increasingly sterile environments, designed to exclude germs rather than just kill them. For the first time in human history, surgery became something you were more likely to survive than die from. The mortality rate for operations dropped from around 50% to under 10%, then under 5%. Procedures that had been death sentences became routine. Abdominal surgery, thoracic surgery, neurosurgery, all became possible because surgeons could finally control infection. Lister lived to see his revolution completed. Unlike Semmelweis, who died rejected and forgotten, Lister was eventually celebrated as a hero. He was made a baronet, became Lord Lister, received honours from around the world. He lived until 1912, long enough to see antiseptic surgery become so standard that younger doctors couldn't imagine operating any other way. The irony is that it had only taken about 10,000 years of medical practice to figure out that cleanliness matters. 10,000 years of surgery in filth, of reusing unwashed instruments, of operating with blood-caked hands, of accepting infection as inevitable. And all it took to change everything was one stubborn man willing to spray carbolic acid everywhere and document the results. Lister's revolution wasn't just about a new technique, it was about a fundamental shift in how medicine understood disease. Once germ theory was accepted, once doctors understood that invisible organisms caused infection, everything else followed. Hand washing, sterilization, antiseptics, antibiotics. The entire structure of modern medicine is built on the understanding that germs exist and must be controlled. So the next time you have surgery and wake up without a raging infection, thank Joseph Lister. Thank his stubborn insistence that germs mattered. his willingness to endure mockery and resistance, his meticulous documentation that eventually convinced the skeptics. He saved millions of lives by figuring out something that seems obvious now, but was revolutionary then. If you want wounds to heal, maybe don't fill them with bacteria from corpses. So tonight, as you drift off to sleep in your clean bed with access to antibiotics and painkillers and hospitals where the survival rate is actually above 50%, take a moment to appreciate how far we've come. Just 150 years ago, going to the hospital for a simple procedure was basically a coin flip between survival and death. Surgery meant agony. Infection meant gangrene. And the doctors who were supposed to heal you were often the ones killing you. Not through malice, but through ignorance. Think about all the people we talked about tonight. The patients who died in those filthy wards, breathing infected air, lying in beds soaked with the blood of previous occupants. The women who survived childbirth only to die days later from infections carried on their doctors' unwashed hands. The soldiers who lost limbs on the battlefield and then lost their lives to gangrene in the recovery tent. The surgical patients who were strapped to tables and cut open while fully conscious, their screams echoing through amphitheatres filled with spectators. And think about the pioneers who fought to change things. Semmelweis, who discovered that hand-washing saved lives and was destroyed by the medical establishment for suggesting that doctors were the problem. Lister, who endured years of mockery for spraying carbolic acid everywhere, but eventually proved that germs were real and could be killed. Simpson, who gave women relief from the agony of childbirth. Morton, who showed that surgery didn't have to be torture. These people weren't superhuman. They were just observant, stubborn, willing to question the established wisdom even when everyone around them said they were wrong. They looked at the mortality rates, the suffering, the endless preventable deaths, and they said, there has to be a better way. And they found it, not through divine inspiration or sudden genius, but through careful observation, experimentation, and the courage to keep pushing even when the entire medical profession was against them. Medical history is filled with tragedy, with unnecessary suffering, with practices that seem barbaric now, but were considered cutting edge at the time. But it's also filled with hope, with progress, with the slow, difficult work of figuring out how the human body works and how to fix it when it breaks. We live in an era of medical miracles, antibiotics that can cure infections that would have killed you in days, anesthesia that makes surgery painless, antiseptic techniques that prevent wounds from becoming death sentences, vaccinations that have eliminated diseases that once killed millions, medical imaging that lets doctors see inside your body without cutting you open. All of this is so recent, so new in the scope of human history. Your great-great-grandparents might have lived in a world where going to the hospital was a last resort, where surgery meant screaming and sawing and a 50% chance you'd die from infection. Your grandparents might remember a time before antibiotics when a simple cut could turn into blood poisoning and death. You live in a world where these things are preventable, treatable, survivable. So yes, modern medicine isn't perfect. Hospitals can be stressful. Procedures can be scary. Healthcare systems have their problems. But compared to what came before, compared to wards where corpses weren't removed for days, to surgeons who operated with blood-caked instruments, to women who died because their doctors came straight from the morgue without washing their hands. We're living in a golden age. Tonight, as you fall asleep, be grateful for the antiseptics that keep your wounds clean, for the antibiotics that fight infections you don't even know you have, for the anesthesia that means if you ever need surgery, you'll sleep through it peacefully, for the sterile gloves and masks and gowns that keep germs away from your vulnerable body, for all the doctors and nurses and researchers who learned from the horrors of the past and built something better. Be grateful for Semmelweis, who died in an asylum but saved countless mothers, for Lister, who persisted despite mockery and revolutionized surgery, for all the unnamed patients who suffered through experimental treatments, whose deaths taught doctors what didn't work, whose pain wasn't meaningless, even though it seemed like it at the time. Medical progress is built on the suffering of previous generations. Every technique, every protocol, every safety measure exists because someone before you died without it. The clean hospitals, the washed hands, the sterilized instruments, they're memorials to everyone who died from infections that we now know how to prevent. So rest easy tonight. Your bed is clean. Your room is safe. If you get sick tomorrow, there are treatments that actually work, not because they smell nice or balance your humours, but because we understand how disease actually works. We know about germs now. We know about bacteria and viruses and how to fight them. We've figured out so much that seemed impossible just a few generations ago. The journey from those horrific hospital wards to modern medicine wasn't easy. It took centuries. It took countless deaths. It took stubborn people willing to challenge authority and endure mockery and keep pushing for change even when everyone said they were wrong. But they did it. They made medicine better, safer, more humane. And that progress continues. Right now, somewhere, a researcher is working on a cure for a disease that's currently untreatable. A doctor is perfecting a technique that will save lives. A medical student is learning from past mistakes so they won't be repeated. The work isn't finished. Medicine keeps improving, keeps learning, keeps getting better. But tonight, you don't need to think about what's still to come. Tonight, you can just rest, comfortable in the knowledge that the age of laudable pus and blood-stained operating coats is behind us, that if you need medical care, you'll probably survive it, that the hospitals are designed to heal you, not accidentally kill you with infections from previous patients. Close your eyes. Let the sounds of the modern world fade away. Your breathing slows. Your muscles relax. You're safe. You're clean. You're living in an era when medicine actually works. That's something to be grateful for. That's something to help you sleep peacefully. The surgeons of the past would be amazed by what we have now. The patients who died in those filthy wards would weep with joy to know that their suffering led to something better. Medical history is dark and disturbing and sometimes horrifying, but it's also hopeful because we learned, we improved, we made things better, and now you can rest knowing that the nightmares of medical history are just that, history. The present is so much brighter. The future will be brighter still. But right now, in this moment, you're safe and comfortable and drifting off to sleep in a world where doctors wash their hands and hospitals are designed for healing, and surgery doesn't mean waking up with gangrene a week later. Sleep well, dream peacefully. Be grateful for modern medicine and all the stubborn people who fought to make it real. And remember, the disgusting history of hospital hygiene is behind us. We've come so far, we've learned so much, and you get to benefit from all of it, every single night, as you fall asleep in comfort and safety that your ancestors could never have imagined. Good night, rest easy, and thank the pioneers who made it possible for you to wake up tomorrow, healthy and whole, in a world where medicine actually saves lives instead of accidentally ending them. Sweet dreams.